There is also when you cut the nerve, when you transect the nerve, when you resect the nerve. This would be akin to this type of mechanism, where a higher order neuron begins to fire. Now, as I said, I was taught that you never take a nerve, you never sacrifice a nerve, and indeed, if you want to know why people in my field, it's traditionally this is what we're taught. Now, look at how, in my own field, we treat this. We treat this with something that's called a DREZ, D-R-E-Z, DREZ lesion, dorsal root entry zone. And what I would do is I would get a neurosurgeon to basically burn, in a particular segment, the dorsal horn of the spinal cord. So there's a mistake in my own literature, because what we're doing is we're suggesting to destroy nerves in order to treat a lesion that's been generated by nerve destruction. So the bottom line is that what I was told classically, if you would destroy a nerve 100% of the time, you're going to get deafferentation pain, is incorrect. But I would think that, you know, if you look at your hernia series of nerve transection, it proves that not 100% of the time you are going to get deafferentation pain. There's about 20 manuscripts I was able to find wherein people would have very severe classic neuropathic pain after nerve resection in your literature. Okay? The question that, so it does occur. Deafferentation does occur. The problem that we have is we do not know the number of times you have to resect a nerve under your operations before we get that one person who then has deafferentation pain. And let me tell you, that one person is going to hate you because it hurts like hell. Okay? These are very, very severe types of pain when they occur. Now, why is it that what you have proven with respect to nerve resection and nerve cutting, why is it that you can get away with it? And here's my theory. Remember that in the brachial plexus, these are large diameter nerves that hold both motor fibers as well as sensory fibers. And the motor fibers, which according to the Gasser and Erlanger classification of peripheral nerves, are A and B fibers. They are important in some of the sensory problems that we're going to talk about in the first question that I'm going to answer. And so if there is a paucity, if there are very few of those fibers, remember that the three nerves that we're involved with are largely sensory. Yes, they do have a few motor fibers, as brought to my attention to the genital branch with respect to the cremasteric muscle. But they're largely sensory nerves. You don't have a lot of these fibers. If you don't have a lot of these fibers, you may not have deafferentation pain, because a lot of the symptomatology of deafferentation pain is mediated by type A and type B fibers. So, can neuropathic pain be distinguished from nociceptive pain? I think the answer to that question is yes. I think that it is not 100% assurance, but I think that the vast amount of the time you are able to distinguish between somatic pain, i.e. pain coming from skin, from muscle, from a joint, and I will refer to that as nociceptive pain. It's a bigger name, and nociceptive pain is really composed of somatic pain and visceral pain. But we will interchange the words nociceptive and we will interchange the word somatic. I think the answer to the question is largely yes. Somatic pain is mediated by activation of nociceptors. There are pathways, there are neurotransmitters that have been laid down from approximately 20 weeks of fetal gestation. And you can activate these pathways and get pain. Post-surgical pain, pure post-surgical pain, directly after surgery, is mediated by activation of nociceptors. Neuropathic pain does not occur de novo. You have to have an injury to a nerve in order to generate neuropathic pain. It then causes spontaneous discharge, as we've already spoken, and it can change its anatomic pathways based upon noxious stimuli and other stimuli on the nerves. We have a tendency to think of the nervous system as a very complex set of telephone wires. But they're more than telephone wires. They're telephone wires that change depending upon the type of call and who's calling. All right? It is an extremely plastic system. It is a dynamic system. The other way to distinguish somatic pain from neuropathic pain is somatic pain is opioid responsive. Make just a skin incision, give the patient an opioid, patient feels better. In neuropathic pain, the dose-response curve is shifted dramatically to the right. Yes, you can treat neuropathic pain with opioids, but you have to use a lot of opioids in order to do it. When people talk about neuropathic pain, they classically will use certain descriptors that people who do not have neuropathic pain will not use. Now, my friend, my august friend here, Henrik, will tell you that these are non-specific. I absolutely agree. I will change the wording. They are non-pathognomonic, okay? But they are still extremely helpful. If I have neuropathic pain, it can feel electric. It can become in paroxysms. It's suddenly, okay? It can burn. Being from a colder climate, we burn fireplaces in the northeastern part of the United States. And the best illustration of true neuropathic pain I can give you is taking a hot poker from the fire, putting it on your skin, and holding it there the rest of your life. That's neuropathic pain. There are a number of other pathologic functions which we're going to speak about and define for you over the next couple of slides. We're going to set up an experiment here, and all we're going to do is we're going to have stimulus intensity, and it can be heat, it can be pressure, but most of the time it's heat. And then we have magnitude of firing of a nerve. You can measure it downstream somewhere. And you get a normal type of curve wherein if you increase stimulus intensity, you get an increase, and there's a specific slope to the curve. Hyperalgesia occurs in both nociceptive pain as well as neuropathic pain. You cannot use hyperalgesia to distinguish between the two. And hyperalgesia is really a heightened response to a painful stimulus. In more articulate terms, it's a shift of the dose-response curve to the left. It takes less stimulus intensity to cause the same magnitude of pain. There is a primary hyperalgesia. This is mediated by release of chemical mediators at the site of injury, and there's a secondary hyperalgesia that also occurs, and that may occur at the dorsal horn of the spinal cord. The third type of sensory phenomenon is allodynia, and allodynia occurs with neuropathic pain by definition. It is pain due to touch or temperature in a stimulus that's not ordinarily would provoke pain. So immediately you have a large magnitude, and its steep doesn't change too much. Okay, if you have seen the pain of post-herniorrhaphy neuralgia, where clothes rubbing up against someone's skin causes them to basically shake, that is an excellent example of allodynia. And we have hyperpathia. Hyperpathia is a heightened response to a stimulus with increased threshold, also found in neuropathic pain.